Good afternoon, everyone. Thank you for joining us today for this inaugural Global Health Economics Colloquium, and specifically this panel discussion on frontiers in global health economics research. I have the privilege, I'm Kazi, I'm a cardiologist at San Francisco General Hospital. I have the privilege of introducing a distinguished panel today who collectively have an amazing range of expertise in the field of global health economics. I could pretty much spend the entire hour introducing the panel, but I won't. I'll keep these introductions extremely brief. Starting at the very right, we have Will Dow, who's the Henry J. Kaiser Professor of Health Economics at Berkeley and the head of the Department of Health Policy and Management. He's done some amazing work on incentives that I hope we can learn from today, and also has spent a lot of time trying to figure out why Costa Ricans live longer. We'll hopefully learn from that. Next to him is Harsha. Harsha Thirumurthy is a health economist at UNC Chapel Hill. He's also at their Gilling School of Global Public Health. Has done, again, great work on incentives, has had a stint at the World Bank. We'll try and not hold that against him. And he comes to us all the way from North Carolina this morning. So thank you, Arsha, for coming. He is a co-investigator on search. And so hopefully we'll learn about the incentive structures built into the search study that Diane talked about this morning. I am very pleased to introduce Doug. Doug Owens is a mentor and God. Trained, I spent a lot of time learning cost effectiveness from Doug over
See what you can learn from your mentor?
Past a couple of years at Stanford. He is also the Henry J. Kaiser Professor at Stanford, is the director of the Centers for Health Policy and Primary Care and Outcomes Research at Stanford. Elvin Gang is our local representative on the panel, is from UCSF, is an infectious disease doc, and has spent a lot of time thinking about implementation science and about how, specifically with regards to HIV, thinking about how we measure attrition to adherence, et cetera. So thank you, Elvin. And Elliot. You have all heard of Elliot's work today. He is president of Health Strategies International, is a former UCSF investigator. The best way to describe him is that he's been Jim Kahn's co-conspirator for pretty much all of the work that you've done in cost effectiveness.
Quarter of a century.
For a quarter of a century. So I think he deserves a special round of applause for having put up with Jim for 25 years. And a lot of Elliot's work has been in low middle income countries, and so we're really delighted to have you, Elliot. So can we have a round of applause for the panel, please? So I want to start out with discussing the format of the discussion. So we have 5 questions or 5 topics we'd like to discuss and 5 panelists. Each topic I'll start out with a very brief introduction, followed by opening remarks from 2 of the panelists who will speak to 2 different sides of the same question. That will go on for about 5-6 minutes, and then we'll open it up to the rest of the panel and take questions and comments from the audience. I have 2 caveats. We have intentionally chosen these topics to be controversial and nuanced rather than black and white, and so we expect passionate arguments on both sides of the debate. It's my role as moderator to ensure that there are no fist fights, but I offer no explicit guarantees. If it helps, I do a mean CPR, but hopefully we won't need it. The second caveat is I recognize fully it's almost terrifying to present to an audience of such expertise. So if there are folks in the audience who have comments and questions, specifically comments based on your own experience and your own work that you'd like to share, we'd love to hear what you have to say on each of those topics. So without further ado, we'll start with our first question, our first topic. And the question is, should we pay patients to take their medications? When I trained as a med student, the idea that you should even consider paying patients to do what was good for them seemed really strange. And then as I started getting familiar with the literature, it seems like there may be some evidence to support this intervention. So we have Harsha, who's going to argue for payments, including lotteries for patients who take their medications. And then we'll talk about why he thinks this is not such a great idea. So, Harsha?
All right. I was wondering if I should defer to Doug, because he's God and he knows the answer.
Tell you later.
Yeah, okay, you could rule on the debate. All right, so I want to just preface this by saying I have not myself actually done a study on incentives for adherence, but I'm actively thinking about such a study, and so I look forward to this discussion and the feedback. I do know a few things about incentives. I want to talk a little bit about the cases where I'm actively involved in studies that involve incentives. In the case of HIV behaviors, I think we can all agree that there's room for improvement in uptake of medical male circumcision, which is strikingly low in many countries in sub-Saharan Africa. Uptake of HIV testing, which in the context of the SEARCH trial that's ongoing right now, testing is obviously a critical part of test and treat, not surprisingly. And if you believe the models, you need almost universal uptake of HIV testing. And in the SEARCH trial right now, one of the challenges we're actively dealing with is how do we encourage people to test at these annual campaigns. It is not 100%. And so that, again, is an area where we need to see improvement. And I'm going to come to adherence very quickly. And adherence, again, having worked on studies that have other interventions that are not incentive-based, but say, for example, cell phone-based interventions to improve adherence. Having looked at the data myself, I think, and we all agree that adherence is the kind of behavior where we don't see optimal levels of adherence, especially for HIV treatment. And I'm not as familiar with other medications, but still, it seems to be a general pattern. So let me just briefly talk about where I've used incentives and where I've experienced. In the case of the SEARCH trial, we're having difficulty encouraging men to come to the HIV testing campaigns, and what we have done there is to introduce a lottery that anybody who comes to the community health campaign and gets tested and goes through all the activities that take place at the campaign would then be eligible to win a handful of prizes. And the way this is set up, we are paying very close attention to what the program would cost. So we realize that there isn't unlimited funds out there, and so the lottery prizes and the odds of winning are set up so that for about $2,000 we can deliver an incentive intervention in these communities of 10,000 people. So that's a case where incentives, I think, have some promise. I think the verdict's still out on whether this is going to be effective in increasing uptake. In Kenya, I'm also doing a study where we are offering, we're not using the word incentive because it tends to be a loaded term in some contexts, but we are offering compensation in the form of food vouchers for men who come for male circumcision, because that does directly address one of the barriers to male circumcision. I know we only have about 2 to 3 minutes, so let me quickly get to adherence. I think the premise, which I think we all would agree with, is, and I've heard this myself in previous presentations, is for the right amount of money, you could probably get somebody to do anything. So, should we pay patients to adhere? Well, if we really believe that adherence is important and we have unlimited funds, I would say absolutely. But we're in the real world, obviously, we're looking at realistic scenarios. What are the right amounts that we would want to pay? And should we even be considering it? I think we should, because adherence, we've heard a lot of talk about behavioral economics. Incentives have a standard economic rationale, which is that it raises the benefit of doing something. And we like to think that people will do things when you have greater benefits associated with them. I think with adherence, the rationale for offering incentives is even stronger because of this very real situation with taking medications daily, which is that there are some immediate costs to doing that behavior. You have to remember to do it. You have to be willing to tolerate potential side effects. And the benefits of doing that, especially in the case of HIV treatment, beyond the early stage when you see these immediate improvements in your health, when you're talking about somebody who's been on HIV treatment for 12 months or more than a year, the benefits may not be so obvious, and the benefits may seem a little bit further out in the future, or even the costs of not adhering may seem to be somewhat delayed because you won't immediately feel worse if you don't take them. And so in that case, what an incentive could do is really shift the benefit of taking that medication to the here and now, to the present. And I think that is one of the compelling reasons why we should be considering paying people to take their medications. I want to stress that there are some open questions nonetheless about whether this is a good strategy. And I think a couple of key issues are, what is the right amount we should be paying them? Should we be doing lottery-based incentives? And I think lotteries have an appealing feature, which is that they tend to be a little bit more sustainable and cost-effective. And they also have some strong behavioral economics rationale because people do value lotteries more than a small fixed amount of money. The other caveat or the other consideration here is how long should we be paying them? If we take HIV treatment adherence, and I realize there are other forms of adherence that, like TB medications, for example, which is not lifelong. But in HIV, we're talking about lifelong adherence, so am I talking about paying patients forever? I don't think the answer to that is yes. I think what we need to be thinking about is the possibility that paying people to adhere for a short amount of time may potentially form or cultivate good habits where their adherence might stay above the levels that it would otherwise be at if we stopped, if we didn't pay them at all. So I think the post-incentive habit, does that tend to be a good habit that develops? That's an open question, but I think if the potential for that is there, then this is another appealing strategy to consider.
Thank you.
Great. Well, this was set up as a debate, but I don't disagree with anything that Harsha just said. I think I would the premise is that we should be emphasizing different aspects of this. So I would distinguish first between sort of large incentives and small incentives. Okay. So we give incentives every time that we subsidize the price for some medication that we want someone to have. Sometimes we bring the price all the way down to zero, and what we're talking about here is essentially moving to a negative price. Okay, so if we think that there is a strong enough externality or some other social rationale why somebody ought to be taking this drug, then we may be able to justify substantial incentives. I would posit that that's a relatively narrow set of conditions. So where there's an externality, we might think of tuberculosis, so a couple of conditions where there's really an externality. And more often, what we're talking about are small, what people love the word nudge, right? So very small nudges to get it to the top of mind, right? So people often, they want to take the drug, but there are various, we can document all sorts of cognitive reasons why someone doesn't actually go ahead and take the drug, aside from having minimized travel cost barriers and that kind of thing, which some incentives are designed to look at. But if we're thinking about a nudge, then the question is, are dollar amounts, paying people money, the best approach, or giving people lottery tickets, or giving people food in kind, or text reminders? Often, in many places that we're working now, many people have have cell phones, and there are other approaches to nudging people that may actually be much more cost effective than even very small incentives. And I think we have a lot of work that the profession needs to do to understand what type of nudge is going to be most effective in overcoming whatever kind of inertia or sort of other constraints people have to taking their meds. And again, just following up on what Harsha said, we think of a lot of incentives as being very important for sort of one-time behaviors. because these incentives and the text reminders, all of these are going to wear off relatively quickly. There's a lot of evidence that suggests, after a certain amount of these, people just stop sort of responding, particularly to these sort of very small incentives and nudges. So we think that they're useful for one-time go behaviors, like go get tested. That can be useful. Circumcision is a really controversial one for using incentives. So I was asked to present a paper at the UN a couple of weeks ago in a conference planning for the 20th anniversary of Cairo. And in the Cairo Declaration, there is actually, in the Program of Action, there is a segment where they say, to the extent possible, incentives and disincentives should not be used. Why? Because people are worried about coercion. Right? So even very small incentives, if someone is credit constrained, right, becomes more than just a negative price, the income effect starts to become really important. And so we point to what happened in the mid-1970s. For a couple of years in India, there were incentives that were being used for sterilization. And that has had a really long arm of, even 1994, people were saying we shouldn't think about incentives anywhere. And what they were worried about was, we shouldn't be using coercive practices. But we have to be really careful in many circumstances where there's any possibility of coercion. This is what sort of a lot of the sort of non-economists are particularly worried about, beyond the budgetary issues. And then, of course, once you start to accustom people to the idea that, well, you should be paid to do the right thing, then we worry, okay, are people going to become habituated to getting paid in all sorts of other dimensions if they're going to do the right thing? So we talk about short-term incentives are good for habituating people, but if we use them too often, then they actually really have the possibility of backfiring. So I am actually in the camp where I think that there are some circumstances in which incentives can be sort of very useful. HIV screening, for example, in some of my work, I suggested they can be quite powerful. But I think we have to be really careful in a lot of other circumstances. So, thank you.
Awesome. Can we open it up to the rest of the panel for comments? Doug?
I don't have really much to add, and I agree with what you both said. I think the thing I distinguish among my things where I just don't remember to do something, where a nudge, somebody reminding me, my iPhone app might help me, and I'd welcome that, versus things where there's actually a real trade-off for me. So I know I should have salad instead of fries, and really, is an app or a nudge or something like that going to change my behavior there? It's because I'm struggling with the trade-off, and so that may be where the incentives can help maybe change that trade-off. But I think those, to me, seem like different situations where the things may work differently.
Just to say, I think the rationale for incentives is really what you said, Harsha. There is an externality, which is the potential for increased community resistance, which would argue for some kind of incentive. But I completely agree with Doug that you might be able to get the behavior you want without using cash, because cash could have the long-term effect of eroding sort of the social capital of people feeling like they need to be paid to do things where we would prefer that they, and we, it's not us and them, but all of us, would internalize the social responsibility of keeping healthy and keeping our neighbors healthy. So again, it's sort of an empirical question. Do the text messages work? Can you get sufficiently high adherence? But that would certainly be my first line of defense.
Can I just make a comment? Or
Go for it.
Do you want to? Well, one comment. I think the text messaging intervention has come up, and I do think we need to be very open to other interventions that may be obviously even potentially less costly, more effective in convincing people to adhere or getting better adherence. And I've done some of these interventions myself and evaluated text messages. I think we need to be a little bit more nuanced about it, in the sense that we have to realize that text messaging may be a very good solution and the right solution for a lot of patients in countries where cell phones are ubiquitous now. And it may even be the right solution for the majority of patients. But at the same time, based on data we've collected on the characteristics of how people make decisions, and people vary in their ability to weigh these costs and benefits and how sensitive they are to the present, the here and now costs and benefits. And I think in that sense, we may want to think about incentives as being the right solution for a certain class of patients that have these decision-making biases or errors that they make, right? So I think if we were to open up the toolkit of interventions, it may be the right intervention for patients that, based on screening questionnaires, these are patients who seem to have particular difficulty putting some of these future benefits, keeping that in mind when they have to make these decisions.
So I have a question. So just to quickly summarize, there were three sets of ideas that we saw, or three sets of sub-questions that we saw come up. One is, do these financial incentives work, right? So there's that one question, do they work at all? The second question is, are they ethical? Are there unintended consequences of using these incentives? And then the third set is, are they sustainable? Can we do this for a long time for all the kind of health behaviors we want to induce? So we've talked a little bit about whether they work, and I appreciate the pointing out that when you have a one-time behavior, circumcision or screening, it may be easier and there are more compelling data for that kind of a behavior than saying take your cardiovascular hypertension medications for the rest of your life. We don't know if these incentives work in the long term. And Harsha's point that maybe if just providing 6 months may create the habit, we don't know. We should definitely test it. I wanted to briefly focus on the ethics of this. Is anyone concerned, and Harsha, I'll let you go first, that by building in these incentives, we may actually be antagonizing patients and both kinds of patients who take their pills regularly without being paid for it may now say, well, I should get paid for these pills because, why not? And then the other group is the people who are unable to take their pills or do that behavior for whatever reason. So if incentives are built into weight loss and there is, a single mother who can't actually make that target that you've set up, does it permanently disinterest her in engaging with you or with the healthcare system? Are you concerned about the ethics at all?
Well, I mean, I think as I've thought about doing this in settings in East Africa, I think the most important concern I had is a slightly different one, which is that in some cases patients may not tolerate the medications properly, and so if you are incentivizing it, are you somehow perversely, coercing them into taking these medications that ideally they may not be well suited for? So I think that's an operational question that we have to address. And my understanding is that these are not, I mean, if they're rare events, then I think we can weigh those risks in a way that suggests that the intervention could still go forward for a lot of patients.
Does that build in, just along those lines, if the incentive is large and overt, does it increase the stigma of not being able to take your medications? I mean, this person who can't tolerate the medications now has her family looking at her and saying, because you can't take your medications, I'm not going to get that fancy gift that everybody else in the community is getting?
Well, I mean, again, I think it has to be in the right context. I mean, if you can deliver the intervention and have it be such that, for example, you set a threshold that's not, 100% compliance, maybe there's ways to get around that. I think at some level, any incentive intervention has to deal with this problem that if you don't meet the condition, you're not going to get that payment. And I think there may be some adverse events that take place as a result of that. I'm not sure. I think you'd have to look at other studies which have been done on incentives to learn whether that happened very often. So, this might be a question for Will in the trial you've done in Tanzania. If that happened often when people fail to meet the condition for STI free status, were there repercussions in their households? I think that would be an important question we want to ask. But I'm not convinced that it's necessarily a one-to-one kind of thing where failure means something bad happens.
We had a question from the audience.
So, you sort of shifted the discussion a little bit from from individuals to families, which I think is important, particularly when we talk about other cultures. What about communities? What about lotteries where the community, if there's a certain percentage of participation, that the community would receive, say, a new will or some kind of incentive? Are those overly coercive, or are those appropriate for those cultures where there may be a village headman who makes lots of decisions and things like that?
Well,
This is always going to be a trade-off between different objectives that we have socially. There is the possibility in anything that we're doing in the global health arena, anytime we're intervening, that we're going to be creating pressures that individuals feel either socially, psychologically, to get with the program. And I think that this is one of the really tough sort of balancing acts that we have to pursue anytime that we're intervening in these populations. I think that the more these are efforts and ideas that are generated by the community themselves, and the more acceptable they are, and the less likely it is that we're sort of imposing sort of coercive issues on individuals in that society. So I think it's the more that we can educate people about the ideas that are being done elsewhere and help stimulate ideas, but really sort of support those ideas which are being sort of locally grown, I think the better. But this is something we're never going to get around. There are always going to be some people potentially hurt.
Okay. We'll move on to the next question. And so this is moving to the provider side of the argument, saying, should we be using incentives, financial or otherwise, but specifically financial incentives, to help move performance amongst providers? And so the question was, should we pay providers based on performance, or should we rely on their intrinsic motivation to do the right thing? And in this particular question, there will be overlap with the questions we've just discussed, but I'd also like to focus on what, if we decide to go that route, what is the right way to do it? So we'll start out, I think Harsha is talking for, and then Elvin is talking against.
I was going to say, you all probably think that all I care about in life is money, and because I'm arguing in favor of incentives and for patients as well as providers. But that said, I am an economist, and I think economists have long believed in the power of prices and monetary signals in shaping behavior. So I'm happy to stick to my roots in that sense. So I think let me just preface the comments by saying that it's obvious to many of us. I think nobody would find it controversial if I said that in most settings, say in the private sector, where what an employee does primarily benefits that employee themselves and the employer, that paying those employees to do their job better or to do more of it is generally going to be a good idea. And I think we see plenty of examples of that in the private sector. The context in which this becomes particularly interesting, I think, is what about employees who, by virtue of the work that they do, it's not just their employer that they're assisting. It's not just even themselves that they're kind of working in favor of by drawing an income or a salary. But what if the work that they do is creating benefits for others? And obviously, in the case of providers, they're benefiting patients or benefiting their communities by doing their work, and there's a tendency, I think, we have to think that the reason the providers are there is that is an important part of their objective function, is to help patients who come through the clinic or to help people in the community or improve overall health. And so in that context, does paying those providers, and by providers here I want to be clear, I'm not talking only of the MDs in health facilities in low-income countries, but also clinical officers nurses, outreach workers, all of whom are part of the care delivery system, community health workers even. Are we, by paying those people for doing their job better, somehow displacing that inherent motivation that they might have had for doing their job day to day, right? And just to fix ideas and terms here, the inherent motivation or intrinsic motivation is what we would call the performance they do without any additional bonuses or any extrinsic motivation. And I think that in general we want to think about this carefully when the nature of your work is something that I would say has benefits to others potentially. We want to be careful because if the task that the provider is doing is somehow inherently interesting, we want to be careful that paying them doesn't potentially destroy that interest that they have in the job. So I think that's one criterion I would want to use, but I'm not saying that this is necessarily going to be true in all clinics, and that's something I want to come to in a minute. If the task is very noble, or if it has some positive value associated with it, again, we want to be careful. So far, I'm actually kind of arguing against this, but I want to come back to this a bit.
You're making Elvin nervous.
If you pay too much, yeah. I'm trying to. If you pay too much, there's a strain in the behavioral economics literature that says if you pay people too much to do their job right, they actually get nervous and they don't do it right. So if you put too much at stake, and I don't think that's something we're going to be dealing with here. And if you pay them too,
you're into that experimental design.
yeah, well, that's something to be careful about. If you pay them too little, that's the other concern. But here's why I think it's something we ought to be considering in low-income countries. The task that providers do in these low-income countries, yes, it is inherently interesting. I mean, I think people wouldn't go into that line of work at all if they didn't find it interesting. But I don't think that is a decisive criterion necessarily. And I think it's something that we, as researchers, many of us have chosen these careers because we find our work inherently interesting. I think many of us have outside options that might be more lucrative, et cetera, but we're here because we find it inherently interesting. But I don't think we want to make that assumption in all cases, at least in the settings where I've worked, particularly when you're talking about facilities where resources are very limited. It's not necessarily an environment where people are as motivated intrinsically to do their job. And so the issue, I think, is that in low-income settings, you can think about the value that people associate with an extra dollar of money or an extra $100 of income. It's what economists would call the marginal utility of income. In low-income countries, that marginal utility of income tends to be quite high. And so I think incentivizing somebody to do their job well can be quite powerful in that context. And it may well be powerful enough to offset any adverse consequences there might be in terms of making them lose interest in their work. And so it's this concept of marginal utility of income, i.e. where salaries tend to be low, that incentive can be quite effective in achieving better outcomes. Some key questions I would want to think about while going forward with paying providers. What exactly are we paying them to do? Are we paying them to say, if 95% if all the patients in your clinic have undetectable viral load, or if there is no more anemia in the communities that are served by your clinic, I don't think that's the right strategy necessarily, because the mapping between what a provider does and the achievement of that health outcome isn't necessarily so clear. You want to incentivize something that the provider maybe has better control over, like delivering vaccinations or making sure that that mothers are receiving a first antenatal care visit, et cetera. So that kind of health indicator that you incentivize is important. Obviously, I said paying too much is a bad idea, too little is a bad idea, but still, what is that right mix? And we need the studies that would actually tell us what the right amount to pay is. And I think the same issue of habituation, potential risk for incentivizing people to do their HIV care really well, does that mean that they do their other non-incentivized responsibilities poorly? We want to be designing incentive schemes that don't necessarily set us up for failure in that other dimension. So thinking about those considerations is important, but nonetheless coming back to this basic idea that providing an additional reward for increased effort in low-income settings may be worth considering.
Evan?
So thanks, and this is a really interesting conversation to be a part of. So I think that let me start by taking a step back and thinking about this conceptually. So the question up here is, should we pay providers based on performance? So I think before we decide on whether or not this is the right treatment, we have to make sure that we know what the diagnosis is. And in many settings, if the diagnosis is one about motivation, then this perhaps is the right treatment. But I think that healthcare settings are incredibly diverse and heterogeneous, and particularly in low-income settings, there may be many other barriers, capabilities, opportunities, knowledge, et cetera, that will that provide a context for how providers behave. So without the correct sort of diagnosis, I'm not sure that this strategy in general would be one that I would, at least on this panel, endorse. So I think that is an issue. So yesterday, I tried to, again, systematically review the relatively large literature on this issue, and I think that instead of trying to parse the work that's been done, to take a step back and look at this in the very opposite way, which is anecdotally. So I started to think about what this would be like for me. So I'm a trained clinician in infectious diseases, and the truth is that I think the practice of medicine, I'm not going to make a case for that it's an art, but certainly it's a process in which you prioritize things. Even if you have a relatively sort of low volume clinic, you still prioritize things. You never address everything with every patient at every visit. And so an incentive to do X or Y perverts that process of prioritization. So like if you say to me, if you get a hemoglobin A1C of under 6 for all your patients, you're going to get a bonus. Well, even though it's good for all patients to have a hemoglobin A1C less than 6, for a given person on a given day, that may not be their most important issue. That guy may have a hemoglobin A1C of 6.5, but be using methamphetamines heavily. And it would be better for me to address the meth use than to tighten up the diabetes further. And so that kind of extrinsic force, it's arguable that it fundamentally sort of undermines the practice of medicine. So to take another, that's sort of an operational argument. In other words, if you could always incentivize everything in the right way, then maybe this would be a good idea. So I'm going to go a little bit out on a limb here, but so Bob Baring, who used to be the dean of the law school at Berkeley, teaches a class in Chinese, the history of Chinese law, and the two large threads in thinking are Confucianism, which says you should just do what's good, and legalism, which says we're going to tell you exactly what you should do at all times. And so in the imperial code, they would say, okay, you can't kill people, you can't steal things, and then say you shouldn't go outside past this stream after a certain time, and you shouldn't kick other people's dogs, and you shouldn't cheat when you're selling peas. And so this thing goes on and on and on and on forever. And at the end of the day, the last thing that it always says is you shouldn't do what you shouldn't be doing. Because, so if you wanted to give physicians a list of things to do, you would never be able to come up with the right list of things. And at the end of the day, you should say you should do what you should do, and that no longer allows you to extrinsic to incentivize good practice. Anyway, that's a little bit of I'm playing the devil's advocate here, but that's kind of what how I would play that card.
Awesome. Elliot?
Great. I'd like to tell a tale of incentivizing providers and not try to draw a conclusion from it, but just relate it to you and see what you think. I managed a blindness prevention and control program in Nepal for 7 years, and during the first few years we were doing about 2,000 cataract operations a year. It went up a little bit because we would train new Nepalese ophthalmologists and ophthalmic assistants, open up new centers, do some more eye camps. But there was a ceiling on productivity, which was due to the fact that, as is the case in many developing world settings, the doctor's main income came from private practice, and they needed to do well because they wanted to put their kids in good schools and take care of their families. And so our ability through exhortation that they should do more eye camps and go out to remote hill areas and do lots of mass cataract surgery was of limited effectiveness. So moral suasion came to an end in terms of our ability to reach the full backlog of roughly 100,000 people who were blind from cataract in Nepal at the time. And so I had the idea of starting an incentive scheme where physicians would be paid per operation that we did. And it was kind of elaborate because we paid a little more if they did it in the hill areas and more during the rainy season because we wanted to even out the caseload so that the facilities wouldn't be overwhelmed during the eye camp season. We wanted to spread it out. And so it had a few bells and whistles like that. And it seemed to me an instance of the development economist Albert Hirschman's idea of being a trait maker or a trait taker. So as an outside person who's coming to work in a developing country, you have a choice to either accept the traits of the country where you're working, that is the customs or the MO that's there, even if it's not consistent with what you ultimately hope to achieve. That would be a trait taker. You accept the traits that are there, or you attempt to be a trait maker and change the norms, which is what we originally tried to do. It failed. And so we became trait takers, which is to say people are going to respond to financial incentives. Let's do that. So we put this incentive scheme in place, and surgery increased by a factor of about 10. So we were doing 20,000 operations a year. It's just skyrocketed. The ophthalmologists were wildly enthusiastic about it. We brought good equipment in. They felt acknowledged. We're extremely productive. We're very proud of what they were able to do. And their incomes were higher than what they would have been earning in private practice, so they were happy. And the question was, well, how long does this go on? How long can this be sustained, right? Because it's all external money. And what happened was Nepal became so visible on the radar screen of other NGOs and also USAID and other donors. Money just kept coming. Everybody wanted to be part of the Nepal Blindness Program. And I had a conversation with Ram Prasad Pokhrel, who was running the program at one point, and I said, well, when are we going to become self-sustaining? And he said, we are self-sustaining. And I said, well, what do you mean? He said, we're self-sustaining in NGOs. And that was it. And to my knowledge, I don't know the details of what's happening in the Nepal Blindness Program now, but I believe it is still heavily dependent on foreign assistance. And it is also one of the model blindness prevention control programs in developing countries in the world.
So long we have a question.
Worried about the team problem and everything and how you fuse it down through the rest. I mean, the nursing, the staff, associates, and so on. I think my question is probably heard.
So the question is, how do you spread the incentive out
Yeah,
amongst the various
the
members?
views. How do you spread it out or even monitor it through the whole system? And how do you make the incentive such that maybe for the doctor, he's working harder with the auxiliary staff and so on to give him the support that he needs in order to produce in accord with the targets?
It's something I wanted to touch upon earlier. and it also ties to one of the comments that Steph was making earlier. So I wanted to be clear that when we think about incentives, we want to figure out what to incentivize and how much, et cetera. But there's also the question of who, and I think there's a strong case you can make against incentivizing individuals in these clinics because it's hard to attribute, the effort that goes into improving a health outcome in the population level to any one provider. The example that at least I found very appealing, and I know there are counterexamples, but the one in Rwanda, which was a large-scale provider pay-for-performance initiative, there the money was awarded to facilities, I believe, in block grants. Now, it was at some level left to the senior people at the facility to determine how the money got distributed. But I think what you have to rely on there, in terms of minimizing the potential of that to get abused, is that theoretically you would think that the person who runs the facility wouldn't be able to achieve the target that would get the block grant without actually motivating all the other staff in that facility. So that is a kind of natural checks and balance against the facility head or the chief of that facility capturing all of the money that comes to the facility if they meet their target, right? So month after month, that facility is not going to achieve those targets if the chief is keeping all of the resources that come from the government. I think the related point is that if you do go with this notion of giving the team a grant or a payment for meeting a certain performance target, you then actually open up this possibility of leaving the decision making to the facility and the management of the facility on how best to actually achieve, high adherence in patients, or how best to achieve high coverage of vaccinations. And I think this is where it relates to that comment that was made earlier, that you can kind of leave the facility to figure out what's the best way to get the certain outcome that's been specified. And I think that's a good model that is counter to what we've been talking about earlier, which is we come up with an intervention that we think is the most effective one for increasing vaccination or something like that.
I want to give Will and Doug a quick moment if they have comments, and then I have a question from Neelam.
I would again just make the distinction between large and small pay-for-performance programs. So you can think of a large pay-for-performance program which is designed to overcome the imperfect monitoring of sort of unobserved effort. So in the perfect world, the physician is out there, they're doing everything just for the good of the patient. But we know from a huge amount of empirical evidence that physicians, like anyone else, they have an objective function. It depends on the well-being of the patient, depends on how much income they're getting, depends on how much effort they're expending. And a good chunk of that effort is unobserved. And in settings where there's a great deal of asymmetric information, the patients aren't able to monitor, the people who are actually paying these providers aren't able to monitor. The pay-for-performance program is a way of actually sort of monitoring the productivity. And so I think that's where sort of large incentives are important. Most pay-for-performance programs out there, though, if we think what have actually been implemented in the U.S., they're actually very tiny. So it's not enough money that we think in some neoclassical sense it should actually be changing anyone's effort. What they're doing is they're signaling to individuals what has been deemed to be particularly important. And again, this gets back to what is the nature of the signal. You can have a report out there where you say, well, it's very important that you screen all of your patients who have diabetes, you screen their feet once a year, right? Well, we know that doesn't get taken up. If you attach very small incentives to it, we've seen actually sizable changes in some of these types of some monitoring behavior. So there's signals of what we consider to be important, and there's signals that for whatever reason appear to be quite salient in some circumstances. So you don't get that same kind of concern about someone sort of taking the money.
Neelam?
Well, I guess I want to, agree with that particular comment, and also say that every provider payment mechanism has a set of incentives in it. So the fact that somehow doctors are unique in working for the good of mankind is not realistic, of course. They
it's hard
have.
being a doctor today.
Yeah.
Proud.
I mean, fee for service has its incentives. Capitation has its incentives. So, you know, I think what we're talking about really is how do we define performance, right? I mean, performance in fee for service is defined as volume. In DRGs, it's defined as, you know, the shortest length of stay for a particular diagnosis. I mean, we have many different ways of defining performance. And I think that the issue is not to define it too narrowly and to define it so that unless you have a specific situation like Elliot mentioned, we want more people to, you know, be here for eye camps. But in general, whatever you incent, you will end up having some unintended consequences. So it's to define performance more broadly and with a bit more sophistication.
Thank you. I think we should move on to the next topic. So as most of you are familiar, and sorry, go for it. Is it all right? Sure, if it's a quick one.
I think it's quick.
Okay.
Very quick.
Okay.
I just found it two things. One, as you know, I'm a general internist at San Francisco General, so you know, ostensibly not so easy to incentivize, and I think it's amazing how sensitive we are to all sorts of behavioral nudges. But my comment is, I find it funny to say that the United States has not had large-scale incentive programs, because you could argue that fee-for-service is exactly that, and which brings us to the cataract issue. I don't know if you're familiar, but in the United States, cataract surgery was one of the most overdone surgeries. There isn't this clear line when you should do a cataract surgery. Everyone has cataracts over the age of 40. You can do cataract surgery all the time. And it was one of the areas where the Institute of Medicine and then ARC and then other people needed to rein in the cataract surgery. So I could totally see how at first going out to the rural villages, people with terrible cataracts were getting appropriate care. And then I would wonder, have you now just given them a U.S. fee-for-service system where anyone will get a cataract surgery regardless of whether or not they need it? You don't need to answer it, but it's a sort of question that calls into this issue of what do we incentivize and what are the unintended consequences.
And that goes back to Neelam's argument that we need to define performance as part of pay for performance. Exactly. So the next question is, do we need a standardized cost-effectiveness threshold? I want to start out with saying that this is, if you look at this graph, I intentionally didn't label it, there's time on the x-axis. And depending on your political persuasion, you could argue this is the United States deficit or the Republican use of the filibuster. But what this is the number of publications with cost-effectiveness in the title or abstract over the past 5 decades or so. So you can see that there is a lot more interest in the literature in this field. And you would think that given how much interest there is, we've figured out the methodology. You would think. One of the things that you heard today is that in order to do cost effectiveness evaluation, you're comparing drug A to drug B or intervention A to intervention B. You find the difference in costs, you divide it by the difference in outcomes, and you're left with an incremental cost effectiveness ratio. And that ratio could be $30,000 per quality, it could be $100,000 per quality, it could be $3,000 per quality. So the question is, as a society, how do you decide we should pay for this? This is cost effective, right? So you have to have something to compare that to, or compare that with, to decide this represents value for money. And that's called the cost effectiveness threshold. And the question here is, do we need a standardized cost effectiveness threshold? If you think it's bad for the United States, think about how one would develop such a threshold for every country in the world. For the those not very familiar with the cost effectiveness threshold, I should just at least start out with this very simple analogy. You want to be lower than the threshold. So it's not a bar you're trying to go over, it's a bar you're trying to go under. And actually, when you read the literature, you realize there's so much confusion because when you talk about a low threshold, it actually makes it harder to get something through because you're trying to go under the threshold. So I wanted to put that on the screen as we go to the next phase of the the discussion. So Doug is going to argue for thresholds, and Elliot is going to argue against.
Well, thanks very much, Kazi. It's a pleasure to be here. And by the power invested in me by Kazi, I will reveal later what the cost-effectiveness threshold is. I'm not God. I'm not even a health economist, which is just one step below God. So, I don't know where. So let me just say again what the, what the threshold represents, because maybe some of you are not, this isn't your main area of work. So if I have two strategies, strategy A is better and it costs more. Strategy B is not as good and it costs less. And I get some incremental cost-effectiveness ratio, $30,000 per quality. What that means is that's how much more I pay to get an additional quality-adjusted life year. And so the question is, how much are you willing to pay? And it represents, it's a value judgment, it represents your willingness to pay for health. And so I haven't been assigned a position in a debate since high school, but Kazi did do that. And so let me sort of talk a little bit about when you might think about that you should have a threshold. And so think about a situation in which you have a real decision maker and you have a real budget constraint. And that means that, that you have a certain amount of money you can spend on health. You have someone that's making those decisions. And if they adopt a new technology that costs a certain amount of money, they're going to have to take something else and potentially not do it. So that isn't really the situation that we're here in the United States, but is quite similar to, say, the UK, for example, among developed countries. So if you have someone that's really making decisions, the cost-effectiveness threshold represents their willingness to pay for health. And so you could imagine that there's an argument for having a consistent threshold as you look across different kinds of conditions. And let me say, I should have started with this, that although I do cost effectiveness is one of my main activities, I would never put forth the idea that cost effectiveness should be the only criteria in terms of whether you offer or do some service. So there are ethical reasons that you might offer something, or social justice reasons, et cetera, that could completely trump cost-effectiveness considerations. But in situations where that's not true and you're really just worrying about value, or you're getting your money's worth out of doing something, when you're in the situation where you have a particular decision maker like the National Health Service, then you can see that it would be useful to have a consistent threshold, which they do have a range at any rate, so that you could judge things along the same criteria and think clearly about the opportunity costs when you adopt something. What does that mean that you're going to give up? So those are the circumstances, I think, when it makes the most sense. There is theoretical work about how you would set that threshold, done by Alan Garber and others, and it has to do with a number of things: your wealth, your risk attitude, et cetera. But I think the circumstances in which we'd want to do it, or when you have somebody that's really making decisions in the United States, we're not in that situation. We do not have a single decision maker, and so it's very hard then to make the argument. Sorry, Kazi, going off the reservation here, but it's hard to make an argument in our system that we have the circumstances in which a single threshold would necessarily apply. So I think I'll just stop there.
The WHO WHO Commission on Macroeconomics and Health promulgated a cost-effectiveness guideline, which is that in any country, denominated in international dollars, a cost per life year of more than 3 times per capita GDP would be considered cost-effective, and 1 time per capita GDP would be considered very cost-effective. And you see many papers, my name is on some of them, that say things like intervention A was found to cost, $300 per DALI averted. Per capita GDP in Ghana was $2,500. This is a highly cost-effective intervention, the implication being, from an economic point of view, that intervention should be adopted. This is problematic for a couple of reasons. Maybe the most important one is it kills inquiry. It kills inquiry into the question which is really at the heart of cost effectiveness analysis, which is the intervention under question really the best use of the resources given the other available options? In other words, anything below this threshold is cost effective, which totally ignores or lumps together interventions that might be wildly different in cost effectiveness but still meet the threshold. And so it blunts our endeavor to make important distinctions among options that developing countries face. So that's are there other objections to the threshold? I think that's my single most important one in general. And then specifically, the WHO threshold, it's almost impossible not to get under that limbo stick. It's almost impossible to rule an intervention out. That may be by design, actually, but I won't go there. I'll just say as a practical matter, if you look at what it takes to actually be so inefficient as to not to meet that criteria, it's very hard to do. And in fact, Jim and I are working on something which we're not ready to present yet, but it looks as if any intervention that has an effect size large enough to be picked up in an RCT is almost certainly cost effective. It would have a large enough benefit that, given the low cost of resources in developing countries, very likely to be cost effective. So it robs us of most of the value of the cost effectiveness enterprise and doesn't allow us to look in detail at the situation on the ground in the country of interest.
Other comments from the panel? I have a couple of quick questions, and then we can move to questions from the audience. One's for Doug. Doug, do you feel, so when you look at cost effectiveness analyses that are based on the US literature, there is almost a phobia of thresholds, right? Like you're afraid to write there that this meets like a 50,000 threshold or 100,000 threshold. Do you feel like we've gone too far? That we, even though there's no single payer, so to speak, we need to have some consensus on what we think is affordable?
It's a good question, but we don't have a consensus on what we think is affordable, I would say, by and large here. When I talk about this to people who haven't looked at cost effectiveness analyses before, I say that, there are some very rough guidelines. So the $50,000 per quality number, which has been around the literature since before I started this, probably has no theoretical basis. It doesn't really have an empirical basis. But at this point in time, very few people argue about things that are less than that. But there isn't a consensus, and so I view these as allowing people to understand what the trade-off is between health and money. And so I don't think for the U.S. we need to say, yes, it's cost-effective, or no, it's not cost-effective necessarily. We can show that information, and in this case a little bit, value is going to be in the eye of the beholder. And since there's not agreement about that, I think that's why, certainly in some of the things that we've done, Kazi, that we shy away from saying yes, no, because there's not any agreement on that.
Mm-hmm. I mean, I think about the situation of a minister of health in an African country who's deciding how to allocate the limited health dollars in his country and is looking at the list of things that meet the cost effectiveness threshold, which is now the most ubiquitous. And I mean, if I'm that minister, I'd look at this and I would say to myself, I can go broke saving money here. I'm like a kid at a shopping mall. There are so many things that are cost effective and purportedly even cost saving, but it takes no into account. It does not take into account what my budget is, what I can actually afford. So it's totally divorced from affordability, which again, I think hurts undermines the contribution that cost effectiveness can make. It's abstract. It's related to some threshold that came down from on high. And as a practical matter, you're trying to put a budget together in a resource-constrained country. It's of very, very little value. A theoretical point, again, and this is really to the WHO threshold, not to the $50,000 that the origins of that was entirely political, right? It was the cost of renal dialysis when Medicare went into effect, and some senator had a relative that needed treatment. But no, that is the origin of it. But another problem with the WHO threshold is that it's monotonic. In other words, it increases with per capita GDP, but there's good evidence to believe that healthcare, in fact, is a superior good, i.e., the richer you are, or the more wealthy a country is, the more willingness people have to pay for healthcare. So even on theoretical grounds, it seems hard to defend.
Can I just add one comment? I just want to, first, I agree with everything Elliot said. And so we now often do a cost-effectiveness analysis, which is about efficiency. But it does not address this issue about whether something is affordable. Because you could have something that's efficient, but in total aggregate is much more than you can pay. And so, for example, we often now we're doing work for the VA looking at hepatitis C treatments, which evaluating both their cost effectiveness and their budget impact, because the total budgetary implications may be really the thing that decision makers need to understand the most.
One question from you.
I just want to say that just because the U.S. doesn't have a single payer system doesn't mean that there are not public payers making decisions of what they would cover or not. Like we have Medicaid that will decide what services they will cover and which ones they would cover and make cuts every year. And at least this is a way to me that provides some systematic way of making these decisions rather than the very chaotic and irrational way that some of these insurers are making their decisions.
I'll just say I agree we need help making these, and I think value is one of the things that we should be looking at. So I certainly agree with the gist of your comment.
Okay. Now this gets closer to home for me, which is it time for low and middle income countries to pivot their public health resources to communicable, from communicable to non-communicable diseases? And the background is, obviously we know that there is an epidemic of non-communicable diseases in low and middle income countries. 80% of all mortality related to non-communicable diseases happens in low and middle income countries. And it's the leading cause of death in every part of the world, with the exception of sub-Saharan Africa. For another way to think about it, is that there are more diabetics and hypertensives in India than there are people in the United States. There is a lot of non-communicable disease in low and middle income countries. But when you think of countries with meager budgets, how do they prioritize their dollars? And is it time to think beyond, I'm going to say it because I have to, HIV. So we're going to start with, Doug is going to talk about NCDs, and he can't be wrong. And Elvin is going to make an argument for continuing commitment to communicable diseases.
It's just the kind of question you'd expect to get from a cardiologist, Kazi actually said I was just only going to make a few points about this, and Kazi alluded to them. So in diabetes, I just want to take diabetes as an example. In the U.S., we have about 250,000 people with diabetes. China has about 90 million. India has about 60 million. And if you look at age-adjusted prevalence, it's about the same in the countries, about 10%, 9 to 10%. Now, the total prevalence is not the same because the age distribution in our populations is different. Nonetheless, these are staggering numbers, and Kazi's talked about the mortality. Another issue is that detection of these diseases. So let's just take diabetes. In the U.S., about a quarter, roughly, of people with diabetes don't know about it or haven't been formally diagnosed. In China, that's about 55%. In India, closer to 45 to 50%. So a larger pool of people who don't know among those that have this non-communicable disease. So it's hard to imagine that this is not going to be an enormous problem, particularly moving forward. And the numbers projected for 2030, which is just about 15 years, China will go from 90 to 130 million people with diabetes. So in 15 years, they'll have close to twice as many new people with diabetes as we have right now. So these are really very staggering numbers. I'm certainly not going to make the argument that you should stop paying attention to communicable disease. That, of course, is not true. So rather than pivot, I would say that these countries are going to have to broaden their focus to include non-communicable disease. It's going to pose really extraordinary challenges. The challenges that we have here, plus the challenges that they have that we do not have. And I just end by saying that I think this is going to a potential area, and Kazi alluded to this, is how you allocate resources among communicable disease, non-communicable diseases to have the largest population impact. And this is going to be very, very challenging. And it's an area where potentially this group of people could really have a great deal to contribute. And many of us do resource allocation among maybe HIV. But think how much more complicated, and we're contemplating doing HIV and TB or HIV and HCV, but think how much more complicated this problem really is. And so hopefully there'll be people here who will work on these resource allocation problems.
If Dr. Owens is God, arguing against him doesn't bode well. I think that Hans Rieder, the TB epidemiologist, once said that all epidemiology is local, and so when we talk about low and middle income countries, there's no point in lumping them like all together to talk about how to prioritize health problems in them. I mean, India and China are clearly very different than sub-Saharan Africa, so I think that the question of what to pivot, when to pivot, is going to be completely dependent on the setting. What's interesting, though, is that, I think, so the IHME in Seattle has, I think, cornered the market on assessing burden of disease. And the interactive data tools on that website are just really phenomenal. And so, I would point out that if you just go to that website and mess around with sort of countries and continents and stuff like that, 75% of the disease burden in sub-Saharan Africa is still communicable, nutritional, maternal, and so that is the overwhelming burden of disease there. And in addition, I would say that so if you look at adults in Africa, sort of HIV is the number one cause of morbidity and mortality. And I think that one potential flaw, if I could make that assertion about the way that the IHME approaches burden of disease, is that the interpersonal relationships are not accounted for. I think we discussed this briefly. I keep asking this question. I don't think that it's accounted for. In other words, because HIV is disproportionately affects adults in their working years of life, that the DALYs lost for a 30-year-old are very different than the DALYs lost for a neonate, because the 30-year-old has a neonate and several children and also older people potentially to support. So the death of that person has a magnified effect in terms of DALYs lost that's not accounted for. And so even though HIV, TB, and malaria are still the top causes of morbidity and mortality in sub-Saharan Africa, I think those are probably underestimated and potentially vastly underestimated. And so I think that there's no question that the investments in HIV care and treatment need to be leveraged for NCDs, which are definitely coming, but to lose focus on these communicable diseases at this moment, when turning the tide is potentially possible, would be, in my opinion, premature.
I agree with all that. So much for debate. In HIV, it's not. It's also with folks in our center have done work on the orphaned elderly, because these folks in this age group they're not only taking care of kids, they're also taking care of parents, and so it has really very far-reaching effects that may not well be accounted for.
I think it would be, so just, I really liked your comment on all epidemiology being local, because the word pivot was chosen intentionally to be almost inappropriate in this setting, because if you look at even within India, the burden of NCDs versus communicable diseases can vary substantially across the country. The question I have for the panelists is, are there, given your work on the ground, do you see synergies where we could leverage, like you said, Alvin, the systems we're building for for communicable disease control, particularly extensive systems we're building in Africa, to look at to address non-communicable diseases?
I mean,
Go for it.
I mean, Harsh can. Well, I mean, I think that the answer is yes. I mean, Harsh and I are both involved in a study in a project search in East Africa. I mean, HIV is unlike other communicable diseases in the sense that it is a chronic disease and therefore it needs chronic management. And so the system of care to provide continuous, appropriate, chronic management is fundamentally different than the sort of clinic-based system where you come in with an acute issue, it's treated, and then that episode is considered like completed. Even TB, which is treated for whatever 6 to 9 months, is a disease where you come in and you treat it and it's over. So the systems to provide HIV chronic care must definitely be leveraged to provide long-term primary care for all these other conditions that we've been talking about. And the lessons learned, I think, need to be maximally used as it's transferred to other areas. My particular area of work is with understanding outcomes. And so it turns out that if you invest many billions of dollars in Africa and you put many millions of people on treatment, but you don't know what the outcomes are, people don't understand the effectiveness of the response, and you don't understand the value of the overall public health response. But because there's no integrated system for understanding outcomes, and because outcomes are measured over years and eventually decades, we don't actually know what the outcomes are.
This is for non-communicable.
This is for HIV, and so that same issue is going to be true for hypertension, for diabetes, and unless we sort of learn from the lessons from HIV, we'll repeat those same mistakes. So anyway.
Harsha?
Well, I think Elvin touched on the main themes that have come out from the work we're doing in Search, but another issue, a key issue in Africa, and I assume this is also true in India and China, is we're still at the stage where people, we have to deal with the challenge of even diagnosing people, right? So there's a lot of unknown status. And I think that's where a bold approach to, say, HIV, that, test and treat represents one such approach, offers you a really good chance to actually start doing diagnosis and screening, as well as then tackling the other challenge of referring people to care. And to do that together, touching on the issue of cost effectiveness, it's just a far less expensive way to do it than to tackle these diseases one by one, right? So if you're able to set up a campaign where you are doing a testing intervention every year, it's a natural place you might want to also consider screening for diabetes, hypertension. And it's what's taking place in Search, but I think more such approaches would be possible.
There is an operational issue that sometimes the two diseases that you're screening for, or the communicable versus non-communicable, have very different population burdens. So you're talking about 1% of the population has HIV versus 20% of the population is hypertensive in that particular area. You're not going to be able to use the same infrastructure. You're going to have to scale up before you start managing hypertension. But your point is that you have the systems in place that you can leverage.
Yeah, I think the care part is complicated and obviously probably more expensive than just the screening part itself. But with the test and treat strategy, where you do have the objective of actually screening everyone, even though yes, prevalence may be 6% or what have you. If you're able to get everyone through, then you are also have that opportunity to screen the 20% that have diabetes, for example.
All right, so we move on to our final question of the afternoon. And this one is, oh, please, go ahead.
I was just going to make a comment, and from a health, just in answer to your last question, from a health financing standpoint, LMICs are already spending most of their money on non-communicable diseases because most of the budget is going toward hospitals and clinics and a lot of other things. I think the question you're asking is whether donors should shift their focus. Donors are the ones that are paying for AIDS, TB, and malaria. It's not the majority of the health budget of any of these countries.
So moving on to the question on how do we best optimize social outcomes, and this is perhaps one of the longest running questions in health economics, that if you have an additional $100 million, you just chance upon it, and you're the finance minister, is it better invested in healthcare for your country, or is it better invested in interventions that improve wealth, such as, say, education? So focus on wealth versus health. And this is the Preston curve, which basically, it's a cross-sectional analysis when you plot countries, their GDP per capita on the x-axis and the life expectancy on the y-axis. It's non-linear, but the argument is that as you invest, as the GDP per capita goes up, the life expectancy goes up, and so we should focus on GDP per capita. So we have Will and Elliot, and Elliot's going to argue that healthcare is the better investment, and Will is going to argue that we should focus on wealth generation. Elliot?
I'm first? Okay. So first, let me tell you what I'm not arguing. I'm not saying that increases in income are unrelated to improvements in health. They are certainly associated, and they are causally related. Lawrence Summers and others untangled via regression analysis the various determinants of this relationship, and it's clearly causal. Common sense tells us that too. If you're poor and you have 6 people sharing a bedroom, it's really hard not to get TB from somebody who has TB. You have a little more money, you're going to buy more and better food. You're a little wealthier, you're not going to work 60 hours a week doing hard labor. You'll cut it down to 40. Your wealth will improve. This is not in dispute. My assertion is that at the margin, in poor countries, you're going to get greater increases in health by investing directly in health, and probably greater increases in overall welfare. Health is, first of all, it's valuable in and of itself, apart from any other secondary gains. People value health. Secondly, it's an enabling condition that allows the benefits of wealth to be realized. So, for example, you can invest in education, but if the students who are coming to the new schools that you've built are suffering from helminth or undernourished and can't concentrate in class, you're not going to get the educational results that you want. So there's something prior about health in terms of an enabling condition for other areas of social welfare. Also, while I emphasize that investing in health generates health, it's also clear that the causal arrow goes the other way toward wealth too. So to take this child now, he's well-nourished, is not suffering from worms, and can concentrate in class and gets a good education and becomes more productive. The access to reproductive health on the part of women means lower fertility rates, means lower dependency ratios, means higher per capita GDP, and healthier and better educated kids because they have more attention from the child. A healthier population is going to be more attractive for foreign direct investment, which has been found to be highly correlated with increases in wealth status. So there's a virtuous cycle of health generating wealth, generating health, etc. And my position is that you want to prime this pump. You want to get the cycle going, and the efficient way to do it is to start with health. The results are immediate. And we know how to do it. We eradicated smallpox. Polio is on the run. We know how to get 10 million people on complicated antiretroviral therapy in Africa. So we have a much greater ability to increase health status in poor countries than we do to guarantee increases in wealth. One of the great unsolved questions in economics is, why are some countries poor and others rich? And it's paradoxical. There are resource-poor countries that are very wealthy, Japan, Taiwan, Korea. There are highly resourced countries which are very poor. You could name them as easily as I. There are democratic countries that are very rich, but there are also highly productive authoritarian countries like China, India, democratic country, lagging in health. So the question of how we foster wealth is much knottier, and I would say much more that we have much less leverage, can guarantee results with far less confidence than we can predict the results of investments in healthcare.
Good thing. I don't disagree with anything that you said for the most part. I think that's sort of very sensible. It's the question as sort of posed in the program, should we focus on wealth creation or healthcare to optimize societal outcomes, is sort of a strange one for an economist to try to answer just in the abstract, because we think that as societies abstractly are trying to optimize some kind of social welfare function that at a given point in time is going to be a function of both health and non-health aspects, and we care about the present discounted value over some time period, and the discount rate that we use is going to have a big impact on how we're sort of trading off the present versus the future. What we can't really invest in either wealth or health per se, right? Those are both sort of derived goods from particular investments that we make sort of as a government or sort of as some outside entity. And we're investing in particular programs, and so then the question becomes, okay, what is the marginal sort of social welfare increase from some $100,000 that you're saying? Or if I had to take $100,000 out of something, $100 million out of something, where would there be the least decrease in social welfare? And I think that we can. A large part of the job that we have is to identify that low-hanging fruit, and I think our profession has done a good job of identifying various low-hanging fruit that we think could really improve health in the short run at in a highly cost-effective manner. But we can also identify an awful lot of spending in the healthcare arena and the hospital arena, as Neil was talking about, that has very little aggregate sort of social welfare benefit. Okay, so the question comes down to thinking about very sort of individual types of programs, and it's going to be context dependent. So if you think about some of the sort of lowest resource sub-Saharan African countries, then yeah, there are a lot of places where we should be investing in health. We should also be taking money out of some areas of health and putting it into education. And to some extent, both of those are going to be have sort of joint production features, in that they're going to both have some impacts on health, and they're potentially going to have some impacts on wealth. So this is, we think, sort of the Grossman model, that a lot of investments in health are going to have immediate consumption value, but they may have some sort of long-term sort of investment value. And then this becomes a very interesting empirical question. So Elliot mentioned earlier the WHO Commission on Macroeconomics and Health, which argued that there was a very strong wealth impact of health investments. And I think that the subsequent sort of decade of research has pointed out that the evidence base is really much weaker for that proposition than someone just reading the Commission on Macroeconomics and Health report would believe. That over the long run, if you look at those countries that are sort of having improved health, and you look at the best cross-country panel data regressions out there, well, the suggestion now is that actually investing in health doesn't look like it had a very big impact on wealth generation. And over time, over the course of decades, we really need to be pushing that budget constraint out. That's just absolutely essential. Right? We can rely on international donor dollars to some extent, but we're going to have to keep pushing that out. And the technology frontier gets pushed out by richer countries. So richer countries have to keep getting richer so that we can keep improving technology. The poor countries do as well. And if we think of the prior question about the non-communicable disease burden, well, there's some low-hanging fruit there, but the biggest issue is going to be how can we prevent non-communicable disease in the first place? Right? It's really expensive for us to manage this. And so then the question again becomes, well, where should we be investing to prevent non-communicable disease? And if you look in a cross-section of a population in a country that's gotten past a certain point of the nutritional transition, well, more educated, so wealthier individuals in the society are actually taking care of themselves better. They're able to buy sort of better calories, et cetera. Right? So this is sort of complicated as a nonlinear function, but I've got to think that over the long run, the more people are sort of able to relax those budget constraints on themselves, they're going to be eating better. They're going to be able to engage in all sorts of other behaviors, which are going to, in the long run, help prevent more of this non-communicable disease. So I think it's not an either or question. We have to do both, but we have to really sort of think very hard about how we're doing that.
Just one, I also agree with almost everything you said. You
can't say different things and then agree
No.
with each other.
Just one point. The evidence that you were citing that the wealth effects of investments in health were less than some members of the commission had hoped to see has been explained by the fact that because you have increased longevity, and over the short term or the intermediate term, you have a fixed stock of capital goods and land, that the per capita GDP is going to fall because you're going through this transition period in which now suddenly you have more people per productive unit in the country. So that's the way that was explained, that this is a long lag before the full health effects would be seen. So you look skeptical of that.
Any questions from the audience?
Not really a question, but I'm wondering next time we do the topic is bad health good for business, because I can't help but think that in this country anyway, there are entire industries that have emerged around poor health, obesity, food we eat. So when you think about the U.S. health expenditures and life expectancy, it's the depressing curve of the U.S. out there. Right? So I don't know. It would be an interesting.
Yeah, I like it.
To add to that, it's interesting when you look at IMF and World Bank and their initiatives to increase GDP and some of the incentives they put in place to developing countries to lift them up, and the adverse outcomes or the ignoring of health, right? The WHO can make recommendations, but there's no kind of muscle behind it. IMF says you need to do this, and there's muscle behind it. They can disincentivize countries. What can we do as a community in collaboration to help influence the IMF and World Bank and some of the world trade leaders to have a bigger influence on health? Kind of posing that to the panel. Or maybe that's a whole nother session next time.
Quick thoughts from the panel?
Well, I think I haven't followed the WHO Commission report very carefully, but I share some of Will's skepticism about the large cross-country regressions, which can't really do as good a job of pinning down the causal pathway. But I think the empirical evidence from the micro data is pretty convincing that health improvements do result in higher wages. So the term that economists would use, the returns to improving health, can be substantial. So I think those kinds of data could be helpful for policymakers. Going back to something that Diane mentioned in the morning, that ministries of finance don't want to see, if you invest in this health intervention, people live longer. They want to see, if you invest in this health intervention, this is what the economic returns are to the economy. And so those kinds of data could be helpful for convincing donors that these are good investments over and above just their health benefits. But then at the end of the day, coming back to the question as it's posed, I mean, I think it cuts both ways. I mean, India is an example where you've had a lot of wealth that's been created, but not nearly the health improvements. So simply shifting out the budget constraint hasn't done the job there. On the other hand, we've seen examples like the unconditional cash transfers that have been getting a lot of press. Those are, again, creating wealth in these households, and that seems to have done a lot for improving health. So there was no health intervention that was needed there. So very context specific and policy, like what is the government doing when the wealth is being created?
Macroeconomic effects of the structural adjustment programs back in the 1980s. I would think that would be a perfect way to see the interactions, health and wealth.
Any thoughts?
Again, just as in health, there are sort of good and bad investments, right? There's some investments that are designed to improve the economy, which may actually have adverse effects in the economy, and there's some investments which may have really good effects on the economy, which in the short run may hurt health. So I don't think that it's sort of taking sort of one kind of sort of economic policy that was originally intended to improve the economy is really going to settle the debate for us. I mean, it's a good question, but there were all sorts of Poloni sort of documented in sort of Latin America, sort of various adverse health consequences, some of the structural adjustment policies. That doesn't mean that we shouldn't be engaging in all sorts of other policies intended to improve economic growth. For example, education, writ large, which is going to have some long-run impacts on health, but in the short run is really designed more to improve the economy.
So what I'm hearing you argue is that there are some interventions that are focused on the economy, and they may or may not work, but you have to look at the big picture, and the overall evidence would suggest that investing in the economy does help.
No, what I'm saying is that we can't look at, it's not economy or health, it's intervention by intervention. It's what we have to think of. We look on the margin for each particular intervention. So you mentioned Costa Rica earlier. So I look at Costa Rica, which is well above this, on the high side of this curve, and it's a country that's invested a great deal in the healthcare sector, and they have excellent health outcomes. At this point, if I had extra money in Costa Rica, I wouldn't be investing more in the healthcare sector. In fact, I would argue that they could take a whole lot of money out of the healthcare sector and plow it into other things.
Other questions, thoughts? One more?
I was going to say something that isn't directly relevant to this, but I think since there is a consensus that health and wealth are related, one of the things that I find really interesting is there are so many medical problems in developing countries especially that can be averted or treated with little dollars, like childhood diarrhea for $1 a child or something like that, whatever it is. How do we incentivize wealthy people and middle class people to invest in health in order to improve health and wealth? That's one of the fundamental questions that I've always been interested in, and I feel like a lot of times I have discussions with friends or other people and I say, you're making really good money if you, put $10 to doing something in Africa or in, South America per month, you can really make a difference. And for a lot of people, it's not that they can't afford to do it, but so many other things like, well, where's my money going? And, why should I do this? Or why is this my problem and all that? And I think that's sort of an interesting question. I'd like to hear your thoughts or comments.
What I'm hearing from you is that we need another question that says how do we incentivize patients and we incentivize providers, and now you're asking how do we incentivize donors to give the money to make things happen that we know are efficient.
Donors, how do we even get more people to become donors?
Get
people to realize that this is sort of a collective problem and that we share this responsibility to make the world a better place by giving money and trying to help address some of these health problems.
That's a very profound question. I'm going to punt to God.
Yeah.
I think we should have a single cost effectiveness threshold.
That'll take care of it.
Any thoughts though on the question? Is there?
Well, some thoughts, not an answer, but some thoughts. It's a very profound question because it touches on the question of what is the nature of our relationship with each other, so I mean, if there was somebody who was needed medical attention right here, right now, we would all take care of it. There is somebody who needs medical attention right now, but they're not right here. They're in Africa. So that's somehow somebody else's problem. That seems to me a failure of imagination. The person who is in need of attention right here and right now is not in a different ethical category from somebody in Africa. And so I think that progress, moral progress in general, including increased support for public health programs in developing countries, depends on sort of an increasing sense of who we are as human beings and what our responsibility is and who we consider us and who we consider them, and the gradual breaking down of those barriers. I don't offer a prescription for doing that. Those of you who might have read Steven Pinker's book, The Better Angels of Our Nature, sort of an optimistic look at a long, slow trend in that direction where fewer and fewer categories of people are considered other. So whatever we can do to speed that process is good, is helpful.
Evan?
I think that I work in the field of HIV, and so maybe some of the recent sort of trends there have loom large in my sort of thinking about this, but things have changed. And the investments from the global community in the problem of HIV are substantial. I mean, there's always argument about could it be more, should it continue to rise, but there's absolutely no doubt that it's changed the landscape around the world, and I think that it enables us to think about the next generation of questions, which is how to do this in a maximally efficient and effective way, because doing it is on the table. I mean, if it's not on the table, there's no point in talking about efficiency and effectiveness. And so, I think that is, in some sense, where I see that we're at. But
a couple of comments. First of all, I've never seen such an erudite and amicable group of people who could not disagree on a single thing.
I tried.
What's the fun of that?
What's the fun of that? And I want to thank the panelists and Kazi for a brilliant panel. And I just want to say I think we're at the end of the day, and a round of applause for this excellent. Hope you all just enjoyed the day, and I think I heard a suggestion about 10 minutes ago. Then what's the next one going to be about? So we'll start planning.